So I appreciate people showing up today. I want to thank those who did show up today to talk about or to participate in our inaugural event where we're trying to share more information from CMH with our faith partners out there in the community. And this was part of our effort to rejuvenate our community church health partnership that we've had for now probably 20 years. And it is, as I said in a previous meeting, it's ebbed and flowed over the last few years with the participation. And we're now in an era where we are really trying to engage more in the community from our hospital. We did have a meeting a couple of weeks ago where we talked to some of the other faith leaders in our area, and we asked about what are the topics people want to know more about. And the thing that came up, of course, was COVID, and then the vaccines. You know, what are the issues with the vaccines? Are they safe? You know, where do they come from? Or which one should I get, or should I not get? Anything like that. And we are fortunate today. I was able to get acceptance from two key experts at VCU Medical Center to address us today and bring you all up to date on what's going on with the vaccine. So I'm going to do a quick intro. We have Dr. Allison Montpetit, who is a PhD prepared registered nurse who's board certified as in nursing professional development. And is the current director for clinical excellence at the health system. She's previously served as a nurse clinician in the adult emergency department in VCU Health and as an assistant professor in adult health and nursing systems department at the VCU School of Nursing. She received her PhD and her Master of Science in Adult Nursing and Immunology from the University of South Florida and a BS in Nursing from the University of North Carolina in Wilmington, and completed her postdoctoral fellowship at VCU School of Nursing, bridging her basic science immunology training with her clinical practice background in intensive care nursing. In addition, we're fortunate to have Dr. Jeffrey Donowitz, who is a member of the American Academy of Pediatrics, Infectious Disease Society of America, and the American Society of Tropical Medicine and Hygiene. He is a member of the Gold Humanism Honor Society. He is active clinically and is a researcher at VCU Health System. His research focuses on enteric infection, inflammation, growth, and neurodevelopment. And in 2014, he was one of 7 pediatricians nationally chosen by the Association of Medical School Pediatric Department Chairs to participate in a 2-year international research project addressing areas of malnourishment, stunted growth, and oral vaccine failure affecting millions of children around the world. I've heard these two speak on the vaccine, and they are very informative, and I'm sure that they'd be happy to take some questions at the end of this presentation. So I don't know which one of you is going to lead off, but I will turn the meeting over to you.
Yeah, so it looks like we have a small group today. Please, nice to meet you guys, such as it is over Zoom. We have just a couple of slides that we're going to go through to kind of set the stage. And then really the whole point of this is to answer y'all's questions and sort of, if I presented a bunch of slides for an hour, chances are I would miss what's on your mind. So we're going to try and be quick with the slides. And we have some extra slides that may help us explain 1 or 2 things that are common questions, but for the most part, we're really here to be a resource for you all. So just some quick stats. Where are we? These numbers are getting lost, in my opinion. They're big. They've been big for a while, and people just sort of say, yep, a lot of people sick, a lot of people dead, and the actual size of things is getting lost. So just to try and put it in perspective, the U.S. population is 328 million. That's who we are. They're about 10% of the whole U.S. has had this virus at this point, about 31 million cases. There are about 562,000 deaths. It's about 0.2% of the whole U.S. population, but it's literally about the same size as Wyoming. So if all of Wyoming just up and died over the course of a year, that's kind of what we're looking at. And the case fatality rate throughout in the U.S. So case fatality rate, obviously, whether people pass away from this or not is going to be based on a lot of factors, including their access to medical care and those type of things. So it's different for every country and even different for counties and states and things like that. But in the U.S., it's been about 1.8%. And people keep saying, well, how bad's flu? So the swine flu in 2009, which was one of our deadliest flu seasons on record, was 0.02%, excuse me, 0.02%. So not even 0.1%. So it's much more deadly than your run-of-the-mill flu or even your bad flu. So one of the things we've been seeing, so we all know that the vaccines are the way out of an infectious disease. Every infectious disease we've ever been able to rid the human condition of has been due to vaccines, not antibiotics, not antivirals. And so, you know, as we roll out this vaccine over the last couple months, there's been a lot of hesitancy, obviously, and some of it well-founded. But when you look at this is just a slide that the KFF Foundation did, and this is December data, so it's a little bit old. But looking at who is most hesitant in this country, and it's, you know, as you can see, there's a lot of overlap between these categories. You know, just because you're in one doesn't mean you can't be in another. But overall, I think the light blue line is sort of the key, that almost a third of this country doesn't want this vaccine, says they're probably not going to get it, or definitely not going to get it, which is scary. And so it has a lot of people like Allison and myself out there beating the bushes, trying to answer questions, trying to be a resource and get people more comfortable with this, because I am indeed comfortable with it. So I'm going to turn it over to Allison for the nitty-gritty science of this thing.
Oh, thank you. Thanks, Jeff. And I 100% agree. I think we've had so many conversations. I've had conversations with family members. You know, something comes out on the media and I'll get a phone call. And I think what we're here to do is really, you know, talk about the science so that you feel more informed about how these things work. What is the data saying? Because there's so much flurry of information coming forward, and some misinformation in some ways, where they lace it with, you know, fancy terms that all of a sudden it sounds scientific. But, you know, the immune system and immunology is complicated. There are so many moving parts, but at the end of the day, what really matters is that antibody response. And so vaccines are the way in which we can, without having to get infection, we can induce that antibody response. Antibodies are what is protective. You know, when harmful things enter the body, like a bacteria or a virus, really the way we mark things, the way our body knows that this is not, you know, this is an invader in our system, is to tag it with these antibodies. And how the antibodies are produced is quite complicated. So we want to make sure that, you know, that we talk about these simply, but also with enough complexity so you know that it's, you know, we're basing it on the science. And so those antibodies are going to tag the harmful cells or harmful antigens or viruses or bacteria, whatever's coming into the body, to, again, put a flag on it and say, this is not you. So it signals our immune cells to go in and kill it. And so a potent antibody response is really, really important. Now, if we were to keep all of the antibodies in our bodies about everything that we've encountered, we'd be a bag of antibodies. And so our body has a memory response where we don't always have high levels of circulating antibody, but we have the ability to mount a quicker response when we see something invading again, which I think becomes really important, particularly as we talk about efficacy of these vaccines and how long the protection lasts. And will we have to have a booster later? You can go to the next slide. The other thing that complicates things, and on top of the fact that the immune system is a complicated system, is that there are various types of vaccines. And here's just a list of those vaccines, but I think, you know, vaccine technology is so fascinating, and it's not meant to make you sick. In some cases, there have been live virus that have been crippled so that it doesn't make you sick, or it's parts of the virus. And that's really the core concept that we want to bring home today when we talk about COVID-19 vaccines. We're going to specifically talk about mRNA vaccines, but essentially it's taking snippets of viral DNA, or in some cases, just the spike protein, or those little prickly things on the outside of the coronavirus, which is the way in which our immune system recognizes non-self. So essentially, vaccines are meant to deliver this small genetic material to make our cells produce something to be recognized as non-self, and then have the circulating antibodies so that if you are exposed to coronavirus, you have seen parts of it before, so you can have that antibody response so you don't get as sick if you are exposed. You can go to the next slide. Now, one of the other things that I think has been really interesting is that because the Pfizer and Moderna are mRNA based, this is the new kid on the block, if you will, when it comes to vaccine technology. This has gotten a lot of questions around it. And honestly, this is it's really simple from the perspective of the way our cells work. Is we have DNA, which if you think about it as like the recipe, the whole recipe, and the RNA is a small ingredient to produce a very specific protein. So DNA specifically, that's how we express certain proteins within our system. The RNA is a very short piece of that DNA, a transcription of it, or a record of it, sort of, that gives specific instructions on to produce that protein. So in the case of the coronavirus vaccines, what it's giving is just giving the instructions to our cells on how to produce spike protein. So you're not getting viral DNA, you're just getting a very short, small string of nucleic acids that make up the RNA, and it's only the instructions to make it. And so it comes into the cytoplasm of the cell and never gets into the actual nucleus, which is where the DNA lives. That's something that comes up in the media a lot about it. It comes into your DNA and it affects your ability to have children, and there's a lot of controversy around that. But honestly, the mRNA vaccines only come to the cytoplasm. And then it just makes a very specific protein on our cells that our immune cells recognize as non-self and mount an immune response. All right, next slide. So this is just a little more detail about how the mRNA vaccine is delivered and works. So again, the spike protein, which is the little protrusions on the outside of the coronavirus, this is the mRNA sequence. It's only to make spike. Now, RNA does not live, it's not stable, so we have to stabilize it. You know, on the forensic files, they talk about finding DNA and it lives forever. It's very stable because it's double-stranded, whereas the mRNA is very short, it's small, it's single-stranded, so we have to coat it. We coat it in a lipid or a fat, if you will, and then that's injected, and it's that fat that helps get it inside the cell. A lot of other viruses or a lot of other vaccines are going to use a viral vector or a viral transmission into the cell. This uses the lipid where it goes into the cell. Then the mRNA, the instructions live in the cytoplasm, or that liquid phase of the cell, and then it makes the spike that then expresses it on the outside of your cell. That's when your cells start to recognize, hey, this is not me. So I'm going to produce antibodies. So in essence, that's how the mRNA vaccine works. You can go to the next slide. So what is the Johnson & Johnson or J&J vaccine? Again, this is an adenovirus viral vector where it uses an adenovirus to deliver that content of that DNA into the cell. So it's a more traditional mechanism with which that specific DNA is then delivered. You can go to the next slide. Oh.
Sorry, I made an animation here.
No, go for it.
I didn't walk you through it before we talked. So the idea is basically, if this is an adenovirus, it's not coronavirus, it's an adenovirus. It's a common cold virus. We've all seen lots of adenovirus in our life. But basically what we did was it expresses that spike protein. So now you've got an adenovirus floating around with those coronavirus spikes on it. And then we killed it so that it can't make you sick. So now it's just a dead adenovirus, but it's got those coronavirus spikes on it. And that's what we inject. And your body says, hey, those spikes are there, and it makes the antibody to that. So, is this me, Allison?
Yes, go for it.
All right. So, one of the things that I think it's really important to talk about, especially, given this week's news, is how do we make sure vaccines are safe? Because everybody hears about phase 1s and phase 2s and phase 3s, and there's some confusion about what all those different types of things are. So, the normal timeline is what's shown in yellow there. So preclinical, it is before it ever gets to humans. This is all lab work where we're trying to isolate what part of a virus is gonna tip off the immune system and what antibodies are protective, because there are other things on the outside of coronavirus that if we make an antibody to, it's not gonna neutralize that coronavirus. So it's really that spike that's important. Phase 1, very small, where we start putting this in humans, maybe 50 subjects, make sure that nothing goes wrong, really safety, little bit of dosing, but mostly safety. Phase 2, you bump up to about 1,000 subjects, really starting to look at now, as the number gets bigger, even more safety, also efficacy data, where you're measuring those antibodies, and dosing schedules, helping you design dosing schedules and things like that. And then phase 3 is what makes the news. So the big, anywhere from 10 to 50,000 subjects, really looking at safety. And obviously the more subjects you have, the more power you have to detect rare side effects. And so, phase 3 is really what, where the rubber meets the road. Now, the thing about, everybody says, well, I'm nervous because it was rushed. And they say, my friends will ask me, Jeff, was it rushed? Yes, it was rushed. But the question is, how and was safety compromised in doing that? So I think the first thing that people don't realize is that preclinical stage often takes years and years, a decade or more. It's a lot of lab time under the hood with pipettes trying to figure out what part of a virus is going to work. And the fact is that we knew this was coming. I don't think the general public did, but people in my field certainly did. So there have been 4 pandemic crossover events this century. When I say crossover, I mean viruses jumping out of animals and into people and causing an epidemic, not a pandemic. There's only been one pandemic. So there was SARS in 2003, MERS in 2012. There was the H1N1 swine flu in 2009, and then COVID-19. 3 out of 4 of those have been coronaviruses. SARS and MERS are coronaviruses. And so, the idea that another coronavirus was right around the corner is something we knew about. And we'd done all that preclinical work with SARS and MERS. So we actually knew that it was the spike that we needed to target. And all we needed to start working on this vaccine was the genetic sequence of that spike. And we had that out of China before this virus ever got to the US. That was published online out of China. And so we were off to the races. So we basically skipped all the preclinical work. And we knew exactly what we were working with, which saved us, 5 to 10 years. The other thing we did is, even before COVID, there's been this move to combine phase 2 and phase 3. What used to happen was you'd do a phase 2 trial, you'd shut down all your infrastructure, you'd let your coordinators go home, you'd close the site down, you'd submit all that to the FDA. They say, looks good, go ahead and plan a phase 3. You'd say, okay, you plan a phase 3, you hire a bunch of coordinators, pick new sites, and do that. And really that was a wasteful system. And so there was a move even pre-COVID to sort of have a pause, but really not kill all the infrastructure and reboot it, just a pause. And COVID was really a place where, that was low-hanging fruit. The minute we knew we had to get through these trials was to say, okay, we don't need to pause. We can just pause. We don't have to shut it down. And so combining sort of a phase 2, you stop, you look at the data, you go on to phase 3 made a lot of sense. The other thing is that the way the phase 3 trials are designed is you say, we're going to enroll X number of people, and you pick that ahead of time, about 40,000 for these trials, 30 to 40,000. And based on that, and based on, you decide ahead of time what the end point of the study is. So, in the Pfizer trial, I believe it was 183 cases of COVID out of 40,000 people. Once we get 183 cases of COVID, trial's over, we take the blinders off and we say, okay, were those 183 cases in the group that got the vaccine or the group that got the placebo? Now, if it's a rare disease, it may take you a couple years to reach that 183 cases. If it's COVID in 2020, it takes you about 6 minutes. So it took about 2 months for us to really hit those numbers, because there was so much COVID floating around that it really wasn't hard to reach those target values that we set out. Those targets were specified before the trial ever took place, which obviously helped things flow along. And then the last part of vaccine study is sort of what we call phase 4 or post-licensure studies. Once vaccines hit the market, we don't just sort of stop the science there. We are constantly monitoring these things for any adverse effect, because the fact is that a phase 3 trial only has 40,000 people in it, and about 20,000 of them got the vaccine. You may not pick up a 1 in a million side effect, even if it's something severe. And so this week with the Johnson & Johnson, Johnson & Johnson was paused this week because they found a pattern, and whether that pattern is due to the vaccine or not has not been fully sorted out. But there was a pattern, a concerning pattern, and that concerning pattern was 7 cases in 6.8 million doses, so right under 1 in a million. So that perfect signaling that these phase 4, these post licensure studies, they're working. They're catching patterns, and if it's significant, we'll get to the bottom of it. But we want to know, and so those guardrails that we put on vaccines, and this is any vaccine, in order to make sure we're not missing rare but potentially life-threatening or severe things, those guardrails are holding fast. And this week they did their job, which to me was a great sign and a great comfort, because we haven't seen anything like that with the other vaccines, despite many, many more doses of those being given. Sorry, it's not wanting to let me advance here. Hold on, let me see what I'm doing. All right, so the next 2 slides, we're just going to wrap up the presentation, but I sort of want to go through what do we know, what do we don't know, and this is just bullet points. So if there's something that I breeze over that you guys want to know more about, let me know. So the first thing we know is that these vaccines work. They're some of the best vaccines we've ever designed. I mean, if you think about the average flu vaccine, that's sort of 40% effective, 50% effective on a good year. Moderna and the Pfizer are 94, 95% effective at preventing any COVID, and they're almost 100% at preventing severe COVID, which is great. J&J, again, a little less than that, but really an excellent vaccine. For any other vaccine, we'd be looking at 85% effective in severe COVID and going, this is a total win. And so, these vaccines really, really work. We know that the efficacy is consistent across all races, ethnicities, genders, and so far age groups. We haven't gotten all the way down into the youngest kids yet, but at least into the teenage years, there's some signal that this works across everybody. We know that they're safe out to 6 months is the latest data for Pfizer and Moderna. And a lot of people say, well, I'm really worried about long-term consequences. So 99% of the vaccine side effects happen in the first 30 days. This is when your body's immune system is ramping up, it is reacting to that vaccine. And so if you're going to get something that even rare, severe immune-mediated things, they don't happen 6 years down the line. They happen while the immune system is sort of revved up. These clots that we're seeing, potentially with the J&J or that we saw a signal for, all of those were between 6 and 14 days after getting the shot. These were not, you got the J&J and 3 months later you had a weird clot or something. We are seeing some allergic reactions, severe allergic reactions. Out of the 114 million doses given, it is 0.00055%. So very rare. Everybody who's had a severe allergic reaction has had a history of severe allergic reactions. These are people that carry an EpiPen with them because they're prone to that. That being said, not everybody who's ever had a severe anaphylaxis event is getting one of these severe reactions to this vaccine. We know the J&J may have this rare but severe complication. Again, it's about 1 in a million, but potentially severe. I say may because we did the exact right thing. We say, hey, we see a signal, pause. We need all the data on these 7 cases. We need to make sure that there's nothing else going on here. We need to figure out who these 7 people were, what their medical histories were, the details of the case. Did they really have the same type of event, or did it just look that way in the database? And then you drill down on it. The new piece of data in the last month, which is really encouraging, is that at least for the Pfizer vaccine, and we can probably extrapolate that to the Moderna, that it's preventing about 90% of the asymptomatic transmission. So that was a big worry early on, was that this may stop you from getting sick, but maybe you still have the virus and you shed the virus, you can pass it on to somebody else. The data, and this isn't fully firm yet, but there's one decent study that shows about 90% of asymptomatic transmissions were interrupted, which is just great news when we talk about things like herd immunity, because if you're not stopping transmission, herd immunity goes out the window. And sort of ending the spread of this virus in communities. So that's a big new sort of piece here. What do we not know? So we don't know how often we'll need to be revaccinated. We don't know how long you carry these antibodies for. Do they drop off over time? Are we going to need a yearly shot? Are we going to need every 5-year shot or 10-year shot like tetanus? Those are things we don't know, and time will tell. Right now, the data shows that at 6 months out, your antibodies are still nice and high. So it's not 6 months and dropping, it's 6 months and counting, which is great. We don't know about the variants. The variants are still a big question mark in this. There's some studies in Petri dishes that show that some of the variants are not neutralized as effectively as the regular virus, or what we call the wild type virus. That being said, what that drop in, that 10 or 20-fold drop in neutralization, what does that mean in a human? Yet to be determined. So does it mean that all bets are off and the vaccine's not effective? Probably not. My guess, and this is just my sort of guesstimate on it, is that those people, if you see a variant, you may still get the virus, but your chance of going to the ICU and ending up on a ventilator is still going to be extremely low because you got that vaccine. You have some protection, just not enough to keep it fully out of your body, but enough to keep you out of the ICU. We still don't know about safety and efficacy in children and pregnant women. The American College of Obstetricians and Gynecologists is recommending this vaccine for pregnant and breastfeeding women. The data in the DART data, which is rat models that are very good for birth defects, looks totally clean with these vaccines. And we know that women with COVID are about 3 times more likely than their age-related counterpart who is not pregnant to go to the ICU and need to be on a ventilator than non-pregnant women. So the risk of getting COVID is higher. there are only 2 vaccines ever invented that you shouldn't give to pregnant women. Both of those are live virus vaccines. This is not a live virus vaccine. And those live viruses are known to hurt the child, or because they cause birth defects in the child. So that's rubella and that's chickenpox virus. This virus, even though it can make the mom sick while she's pregnant, doesn't hurt the baby very much. It's not like you get kids with limb defects or something like that who got the virus. So, really no concerns about getting this in pregnancy. I can tell you my wife got it when she was 9 weeks pregnant. We knew she was pregnant. This was, several months ago at this point, January. We read the data. We had a nervous conversation around the dinner table, and we said, listen, we're both doctors, we're people of science, and we're going to follow the data. It's not that it's not doesn't make you nervous, but the science is behind you. And then, the last thing is extremely rare reaction. So if it's 1 in a million, we might not have picked it up. I can tell you that for Moderna and Pfizer, we're looking for 1 in 114 million at this point. But there certainly could be these extremely rare things that we're still looking for. But so far, so good. So I think we'll just stop there for the time and sort of open it up to questions so that we have time to answer what's on y'all's minds.
And Jeff, you made a really good point about the nervous conversation around the table. And I think it's really important for us to talk about the emotional impact of making these decisions. Like, they're not easy for people to make. I was part of the team that rolled out the first wave of vaccinations in December to our team members. And there was such a wave of emotion, even from people with a strong science background who have taken care of patients with COVID. So we can't negate the impact and power of what emotion does to our ability to think. And oftentimes when you're emotional and really anxious and nervous, it can cloud your ability to critically think. And so I think the work that you do with the community and with your parishioners or the people in your congregations is really important, because an emotional aspect needs to be validated and talked through, and then you can move into thinking through the data, thinking through the information. And I think our goal was really to help give you some comfort in talking about the science behind it, so that after you stabilize the fear and anxiety, that you can start to have a conversation around facts. And so I think it's worth pointing out that the work that you do is incredibly important when it comes to getting folks to be able to think and make decisions.
Jeff, would you mind stopping the share so we can,
Whoops.
unless you had something else you wanted to show.
Nope.
Okay.
There we go.
And as I said, when we started this was one of our inaugural event, trying to get communication out, but also to hear back from you all if there's things that you want to know, or you've got an opportunity to question two highly regarded experts in the field right now, things you might be hearing in your churches that people are talking about. And, is this an opportunity to dispel myths or concerns or rumors? I can say here at CMH, we've given just shy of 5,500 doses of vaccine. Some of those that's both first and second doses. We've had very good results. I know in the health system, they've given over 60,000 doses of vaccine. They have had, I will say, they've had a few people that have gotten COVID after the vaccination, but had absolutely no symptoms, which I think is one of the things that we wanted it to do. It's just like the flu vaccine. If you get the flu vaccine, you might have a milder case of the flu, but the only way they found out they had COVID is they had somebody else in the family exposed, so they had to be tested, and that's how they found out they had no illness. And that's what we've been told in the meetings with Dr. Bierman, who's the infectious disease chair at VCU Medical Center. So I think it's been very effective. I think about 65% of our employees have gotten the vaccine. We know there were people in the community waiting for the Johnson & Johnson vaccine because it was the 1 dose versus the 2. And now we have the pause on that. We had started giving that vaccine in the community, but we are on pause as well. So I don't know if you all have questions or things you're hearing you'd like for us to address.
I saw a news article just like 2 hours ago that Pfizer's CEO says the 3rd dose might be needed 6 months. So that's coming right from, in news circles already today.
Well, Jeff was part of that, and I saw something a while back. They were thinking it might be needed because of the new variants that were out there.
Correct. The last study I saw on antibody levels, so that's what we're sort of measuring is how much antibody do you have.
Right.
At 6 months looked good after the Pfizer and Moderna. So you still had high levels of antibody. I think the thought is that we can tweak this vaccine slightly and we can cover those variants. And so I think that's what that's about. I haven't, to be honest, I've been writing all day and haven't read news today or press releases. So you're ahead of me. But I do know that both Pfizer and Moderna have been working behind the scenes on tweaking their vaccine to cover some of these variants. The South African variant in particular
Right.
has people nervous.
I think and what I have heard is in a meeting we had earlier this week is the EU variant, which is what B117 is now the predominant strain of COVID in the United States. So that's a little concerning because the other data they shared was it is affecting more children. From the data, I don't know if you all have seen what I know Tom Yackel shared some with us this week, but the incidence of children between the ages of 10 and I think 18 is doubled. And same thing with younger adults, and the older adults are having less effect by it, which is maybe because they all got the vaccine. All of them wanted the vaccine. So,
and the vaccine is effective against that strain, which is good.
Yeah.
And the biggest thing that I know I deal with in the church setting is the varying rules of protection between different churches and different congregations and different so why can't we do this because all these other churches over here are doing this, and I mean it's we're trying to base it on science and not what we want, and it's really difficult. I was fighting a losing battle on that, so I'm not quite sure how to, other than the fact that we're trying to be careful and follow the science and get your vaccine so that we can open up.
But Jeff, I'm not also correct, or Allison, that even if you've had the vaccine, you still need to mask and all of those things, because it doesn't mean that you can't get it. It's just that you're going to have a lesser case. Is that correct?
That's correct. We have not lightened up our masking requirements in the health system at all. So even if, and I know the CDC had come out with guidance about, if you're with someone that has had a vaccination, is fully vaccinated, that you could, take down the mask. But, here, even though the majority of our team members did partake in getting Pfizer or Moderna and are fully vaccinated, we have not lifted the restrictions within the health system at all. So
Right.
You're absolutely correct, Scott. We haven't changed a thing.
Yeah.
My understanding is we don't have enough people yet to be able to do that, which is,
Right.
I mean, if we get everybody vaccinated, then yeah, we probably could, but we're not there.
We're not there. And I think, everybody is anxious to get back to how things used to be, everybody. But when we start making progress in that direction, which we will, the thought needs to be is where do you take your foot off the brakes and first, and things like masks are so effective and so minor in the world, in terms of what they're preventing us from doing. If you told me that we were allowed to get back to in-person worship, but and be in the same room and be present with each other, but you had to have a mask on,
Right.
you know, that to me is a fair compromise. If that helps protect from those 10% of transmission events that are still going on, the 5% of people who are still going to get severe COVID despite getting the vaccine. And none of that includes people that are immunocompromised. So the people that are immunocompromised, the folks with cancer, the folks with other reasons, their body probably won't respond to this vaccine equally. And so, you know, you never know who that is in your community. And for the time, we still need to keep up some of these things to protect those folks. And so, you know, when it comes to wearing a mask, that just seems like not the biggest sacrifice we could make compared to some of the other things that we've all sacrificed this year.
I think Dr. Bierman said something interesting the other day. I think it proves that masks and sanitizers and hand washing work is there were only 3 cases of flu in Virginia this year. 3. So that's pretty impressive considering what we've had in prior years. So we know that works.
That's huge. That's huge. But you just said something, Doc, a moment ago about those pre-existing or those other diseases and how the vaccine may affect them differently. We in this community serve a much older community. Many people have other diagnoses of heart disease or COPD. So the vaccine, are you saying the vaccine has a different effect or it may not be as effective with those persons? We just don't know.
So the only conditions that are going to limit how effective this vaccine are those where the immune system, so like Allison showed, the whole game here is to trick the immune system into thinking it's seen this virus before, right? Mm-hmm. And so if your immune system is not up to par, and when I say up to par, I don't mean you know you're a little weaker because you're elderly or frail or those type of things. This is people whose immune systems are suppressed. So this is people on chemotherapy. This is kids who are born without arms of their immune system. This is bone marrow transplant patients or transplant patients. You know, it's those groups that are not going to make the antibody to this vaccine the same way that somebody else might. It's not a matter of different side effects. It's not a matter of worse adverse effects or different adverse effects. The vaccine may not affect them at all, which is part of the problem because their immune system is going to gloss right over this and not have the power to make those antibodies that it needs.
So I guess I'm also considering the efficacy, that it will still be as effective for the diabetic, for the heart disease. Okay.
Yep, and the phase 3 trials for both Moderna and Pfizer did a very good job of trying to include some of the conditions that we know are associated with severe COVID: diabetes, obesity, hypertension, and heart disease. They really sort of went out of their way to recruit a good sample size of those people so that they can make that statement on the back end. So yeah, those type of things, absolutely as effective. Elderly as well. Yep.
Does anybody have any other questions? I recognize
I do have a question. A long time ago, before the vaccine was really even available, we were hearing that if you had COVID, you don't need to get the vaccine. And last thing I heard was they still want you to get the vaccine. So what's the difference there?
Yeah. So the idea is that after you've had the virus, you're going to make some antibodies. What we've shown, because things change as more data is available, right? So what the data ended up showing pretty clearly was that it's widely variable how much antibody you make in response to getting the actual virus. Some people made a ton, some people made almost none. You couldn't even detect it. And we really weren't terribly good at predicting who would get what. The people with the more severe disease tended to get higher levels, but it wasn't always the case. And we had people with very severe disease who 3 months later were able to get infected again. And so one, you may not make a lot of antibody, and two, it drops off at different levels for people. So some people 3 weeks later it's gone, other people 3 months later it's gone, and other people 6 months later it's still there. So it was widely variable what we were seeing on that front once the data came out. I think we were all a little more hopeful that if you got the virus, you'd have sustained protection, and you wouldn't have to worry about vaccinating that crowd. That being said, what we've seen in the vaccine, even in the people who got the virus before they got the vaccine, is the vaccine sort of uniformly gives you very high levels of antibody for a sustained period of time. And so that's the recommendation there.
Okay, and a follow-up to that, if you had a severe case of COVID and you get the vaccine, is there any data about those people get a more aggressive reaction?
Robust response, you mean?
No, their side effects tend to look like everybody else's, is what the data has shown. Yeah.
Sandra, did you have a question?
I was just on, and I've got to plug in my computer because I forgot I had it on all day. No, I was just, the thing I struggle with is, and talking with parishioners, our folks have been great about, we're meeting in, because we're a small church, as well as Zoom and other, but the, because we're learning about it so much as we go, and there's so many folks that we're just, as a people, we want absolutes. And so we hear something and it should be forever and ever, amen. And I think this is so helpful to talk about it in a way that everybody can understand it, and what we've learned, and the progress, and why our information is different now, or why we're continuing to wear the mask. Or to me, that's the people I work with, is a really important thing we can do in our relationship between the hospital and the churches.
Okay.
We had the same thing in the health system, and we continue to, we talk about pivoting, we talk about being fluid. Like, as more information would come out, it was really challenging, particularly for our frontline. I mean, I was in the middle of the medical respiratory ICU, and people are concerned, like going in, like, we don't know as much about how it's transmitted. We aren't really sure, like, do I need to cover my hair? Do I need to cover my shoes? Do I need to shower before I go home? Am I going to expose my elderly, parent that's living with me, or my child? And I think that's just the human condition of wanting absolutes. And what we've really recognized is that leaning on each other, and again, comforting each other, and then saying, what do we know now? How can we make decisions now? And do the best that we can, and knowing that we're in it together, and our chief nursing officer will say, we offer grit and grace. And it's constantly grit and grace. I mean, that's been the message. So I think we do have a shared experience, even from, at the front line all the way in the community. And I think this is something that brings us together.
Yeah, Allison's right. The ability, it has been very hard throughout just our experience in the medical center, staying fluid. And that's been a message from leadership, which I think is just spot on. It is from day one in this pandemic. I remember, I don't know whether Dr. Kellerman was the one who coined this phrase or whether he stole it, but to say that, we're building this car as we drive it. And that's what this has been. Science, the way science works is somebody does a small study, not a great design, maybe retrospective, but they see some signal there. And then we try and assess, what did they find? Is it a big enough signal we should make decisions on? What's the proper study to really tell me whether that is, forever and ever, amen, or whether that's something else? And then you plan that study, you conduct it, that takes another 2 months, 3 months, then you get another answer. And so data trickles out, and the papers that are being done on COVID, So I have it set up that any paper published with COVID or SARS-CoV in the title, I get a list of those in my email every day, and it's hundreds of studies a day. I can't even go through it. Every day, and to look at that literature is very complicated, and you get a lot of folks who little things come out and they misinterpret or they misstep, and it's phenomenally fluid, and we're building this piece by piece, and and then we drive it up the road and decide which piece doesn't work as well or needs to be changed or altered, and then we build that part again.
You throw social media in there that just confuses everybody, that they're not basing it on anything. So that's the danger. I mean, I know we were making hard and fast policy here in pencil, because it just, every day something would change, and that's what we were having to do, is adapt as things were being learned and people were coming up with new things that we needed to do. It's been a year of constant change. I have canceled visitation, allowed visitation, told people they can't come. Yes, they can come. I think people think I've lost my mind, but it's just, we've been through 3 waves of COVID here now, and the last one by far outweighed the first 2. The Christmas wave was more than 3 times bigger than the first 2.
Yeah.
And this hospital was 106% occupancy with 40% of the patients with COVID. So it is, we've learned every day. Well,
Yeah,
I'm sorry.
Oh, I was going to
No, I was just going to ask, saying that with the vaccines out and folks are like, hey, let's go. Allison and Jeff, what are you saying about a wave that we might be looking at now and what to do?
Well, it's really hard to tell. I mean, our numbers are looking really good at the medical center right now, but, they looked good at the second wave, after the second wave. So we just really can't predict. I think, the thing that this has taught me more than anything is to live right now, to accept what is right now, and prepare the best we can for the future, to learn from what we learned in the past. And like Jeff said, like, the masking, the hand sanitizing, the limiting interactions are so simple and so effective in preventing those massive, waves as they come. I mean, viruses are smart. We have no idea if we'll have a variant that's highly contagious and even, and not responsive to the vaccine. I mean, I don't know what you think, Jeff, about a 4th wave, I guess.
I think a 4th wave is very likely. I don't know here in Virginia. We've done better in Virginia than other states, but if you look at places like Michigan, they're in the thick of it, and so very possible. And I think a lot of that depends on us not fully taking our foot off the gas in terms of protections. 25% of the US has gotten a vaccine at this point. That is phenomenal. When you think about it, it's been a little over a year since we started. That being said, that means 75% of the US is not. And so if we sort of say we're going to open up and throw off all the protections that have been keeping our hospitals empty, very similar to how we did at Thanksgiving and then into Christmas, and then it led to the spike. I mean, everybody got around, we did not do a good job as a country about staying away from each other at Thanksgiving and Christmas, and that's what led to the 3rd spike. And so if we start doing that again, we will get a 4th spike. So we're not there yet. We're making great progress, but we don't want to drop the ball here in the 4th quarter.
I can tell you the concern from those of us in senior leadership is that with school opens, another surge.
Yeah.
As I talk about in-person learning, and that we're already thinking about that, and the fact that they haven't gotten the vaccines approved yet for the younger kids, 16 and older is right now all we have. And so we're concerned that if they do go do this, and now we have this new variant that, as I said, has already been more infectious for the 10-year-olds and above, then we're going to see a surge. So,
yeah.
When the problem with a surge is, I mean, sure, if you're not worried about getting COVID, that's one thing. But when hospital systems are overwhelmed, when the resources, when there's no beds available, what happens if you have a car accident, not COVID related, and you need services or a heart attack or, you know, something else? When something else is clogging the pipeline, it impacts your ability to get help that would normally be there. And so it may not be the fear of COVID, it's really about the resource utilization that really impacts all of our abilities to get help when we need it.
And to Allison's point, when we were running this last few weeks, we were running 95% occupancy. At that point, we only had 5 COVID patients in the building, but the rest of the building was full of other patients that were critically ill or seriously ill and needed to be here. But, you know, had that been in the middle of COVID, where would they have gone? Because every hospital in Richmond was full. And so we have ramped up, as I said, over our capacity here. And in Richmond, they've done the same thing. So that's the other, you know, I'm glad you brought that up, Allison. That's a great thing to know, because it's not just COVID. People are still getting sick from normal stuff. So. Well, Allison and Jeff, I appreciate you very much joining us today in our inaugural event. And Sandra and Brian, if you wouldn't mind just hanging on for another minute after we let them go. I know they've got other things to do. I appreciate it very much, and God bless you.
Thank you both.
Always a pleasure.
Thank you so much for your time.